with any colleagues, then please feel free to do so. If you have any questions as we go along, please pop those in the chat box. We will be continuing through all presentations up until the end, where we will stop and invite questions for discussion. So if you have something in your mind as we're talking, please jot it down and either pop it in the chat box or save it for the end of the session where we can talk together. So to talk you through the agenda, so I'm going to give you some very quick updates about what's going on with the NACEL programme. And then I'm going to hand over to Rosie, who's going to take us through the equitable care findings that we have from our data so far. And it's going to give you some insight in how to understand your NACEL data on the data and improvement tool. I'm then going to hand over to Dr. Emily Collis, who is going to talk about a case study at University College London that she's leading on. And then we're delighted to be joined by Dr. Sabrina Bajwa, who is going to talk through how to make changes in practice with a Quality, Diversity and Inclusion Executive Lead. I will then pick up next steps, and that's when we will stop the recording and go to open forum reflection and questions. Next slide, please. So just to give you some updates about what's going on with the NACEL programme. Next slide, please. There's a few things to bring to your attention. The first is that the NACEL 2025 dataset is now finalised, and that it can be found within the Data and Improvement tool. The 2025 dashboards on the Data and Improvement tool include the key indicators, as well as the patient and carer tool, which is 5 metrics, and along with each of the 10 primary drivers that hopefully you're familiar with and can be found in the driver diagram, which also sits on the NACEL website. The Good Practice Compendium is now complete, and that is on our website as well. That brings 2025 case studies into the Good Practice Compendium, which joins 68 case studies from 2024. So we now have a huge compendium of good practice examples, which hopefully are helpful to look at what other hospitals are doing. And there are over 13 examples of equitable care case studies within that good practice compendium. The community of practice has been sitting in the background for about 6 months now, but we are hard launching the community of practice now. So the community of practice is called End of Life Care in Hospitals. It is run by the NACEL team, but hosted by the Q community. And if you go to our website or look at the link that is hopefully in the chat box, that will tell you how to sign up. It's free to sign up. There's lots of benefits of joining Q. And the community of practice functions very similarly to NHS Futures. For those of you who are familiar with that, it's a discussion platform, sharing good practice, sharing resources. The Impact Compendium is also up on the website. This is different to the Good Practice Compendium. It asks the questions around how has NACEL impacted on your service. So there are lots of examples from hospitals about the impact of using NACEL in their local departments. And finally, just to mention about the patient and carer tool developments. This is something that is not new. The patient and carer tool is currently live on our website. What is new is that from August this year, people in the public will be able to look at data for their hospitals locally. So at the moment, the patient and carer tool only shows data at regional and country level, but from August, members of the public will be able to look at their local hospital data. So if you're not familiar with what's going on with that development, please click on that link just so that you can be familiar. And I'll come back to talking about that a little bit more towards the end. Next slide, please. And just before I hand over to Rosie, we're always very, very keen to hear your thoughts on these sessions. What's been a takeaway for you? What's helpful? Where do you want to see us develop further? So please click on the link or scan the QR code and let us know your feedback. Thank you. Next slide, please. So I'd like to hand over to Rosie now, who will take us through equitable care findings. Thank you, Rosie.
Hi everybody, I'm Rosie Brunnett and I'm the Nasal Quality Improvement Clinical Advisor, and I'm going to go through some of the findings and then talk you through about just checking that you're aware of how you might be able to find the findings related to your individual organisation or area in which you work. Next slide, please. So equitable care has been a key focus throughout this nasal cycle, and it's one of the 10 primary drivers that we recognise within nasal as being essential to delivering good care and to improving the quality of care when somebody dies in a hospital setting, and indeed any setting. Next slide, please. We have been focusing our work on equity markers relating to ethnicity. Now, we spent lots of time working out the most appropriate way to help shine a light on some of the issues that are relevant to equity. And the decision was that it was better to focus on one area and help ensure that we within the internal nasal team help you to do that well, rather than spreading ourselves across lots of different areas. We're very aware that this isn't the only factor that impacts on people's care, but this is the area in which we are focusing our reporting on at the moment. There are other things that you can look at within the nasal data that are very relevant too. For example, the impact of age, and we've recently presented some of the data around some differences in age-related access to care. And we hope that that will be something that we continue to share. Spoken language is also available as a filter from your nasal data. So if you want to look at how your results are affected by the primary language that somebody speaks, then that is also available to organisations from their nasal data. Next slide, please. We have some questions come to us as a team about the recording of ethnicity, and so I just wanted to share a particular point about people where their ethnicity is not recorded. So there's two different codes that can be associated with a finding where ethnicity is not specifically designed, and this is when it is unknown, so there is no information about the person's ethnicity, or where a person makes an active decision not to disclose their ethnicity, and that is a code Z. We can see here that in our nasal data, we have found that 86% of people who have their case notes reviewed as part of nasal do have recorded a recording of their ethnicity, and this is the breakdown between whether there is a gap or whether people are making an active decision to not disclose their ethnicity. And in different places there will be different reasons for this. Next slide, please. Equitable care is really central to delivering care, all aspects of healthcare. And it is something that we've included in our State of the Nations report about the importance of improving this aspect of care. So in this report in 2024, and again, it will be in our 2025 report, our recommendations based on our findings about improving equitable care. Next slide, please. So this is the recommendation as it sits in the report from the 2024 data. The important thing is that this can be used to help the narrative around improving care in this area, and has been shared with all the different hospitals, and hospitals have been asked to share that more widely in the areas and the localities, the ICBs, different places in which they work, as well as those areas receiving notification of the State of the Nations report. So we're hoping that these are jigsaw pieces that we can put together to help you all improve the care. Next slide, please. So these are the 5 main findings related to equitable care that I'm going to talk through from the 2024 findings. We're in the process of completing all the analysis and reporting for 2025, so the findings will be updated subsequently and shared when the State of the Nations report comes out in the summer for those 2025 data. Next slide, please. So we've touched on this already, that 86% of clinical case notes in the nasal audit had documentation of a person's ethnicity, and that 14% were recorded as unknown. And then this pie chart below gives you a breakdown of the number of deaths by the different ethnicity categories. So there was a predominance of people who die who are of white British or of white ethnicity, and then you will be able to see the other findings there. And as you can see, the numbers are variable across the different groups, but we have done some statistical analysis with our statisticians to be able to understand whether there are sufficient numbers for us to be able to explain the differences in the different areas. And the numbers are statistically significant in all of the areas that we're reporting to you today. Next slide, please. And this just is a graph that is available in the nasal data that you can see to look at where your trust sits. And I just wanted to share here that the range of documenting ethnicity is quite considerable, with a very long tail of people completing it in almost all cases, but then a sizable chunk where that is very different. So I think I would encourage you to have a look and have a think about where you as an organisation fit into that recording of ethnicity. There's always room for improvement. I think almost universally we can improve to get that number up. But there are some organisations where there is more work to do than others. Next slide, please. And now we're on to trying to show some of the findings that we have. So we know that the experiences of care are inequitable by people who are of different ethnicities. And this is showed through the rating of care that bereaved people tell us about. So there is a much less good experience of care when people are not of white ethnicity, and you can see that in the bars here, and that is statistically significant throughout. So that finding is quite a stark difference, I think, between these groups, and we really want to encourage you to have a think about this and how important it is that we recognise how different people's experiences are. Next slide, please. And this continues around bereaved family members' feedback, around staff members in hospitals communicating sensitively with them. The figures again show a really stark difference between the different groups here. People's experience of care in terms of communication being sensitive, feeling very, very much less good. Next slide, please. And it continues here with a very significant difference between people feeling like staff behaved towards them with compassion and care when the patient was not of white ethnicity. And again, these differences are really stark. And again, you will see that the group where people are of unknown ethnicity are reporting a worse experience. Next slide, please. Hydration discussions are something that we know needs to continue to improve across all groups of people, and that it's something that continues to be a really difficult experience for lots of patients and families, and that's something that we need to improve the way in which we talk about things. You'll see here that there is variation between different groups about the ways in which they perceive that discussions about hydration were had. Again, the largest difference in people relates to people of unknown ethnicity. So this, unlike some of those other ones, relates to the case note review data rather than a bereaved survey. So we are seeing across multiple different modalities of the audit that care is different. Next slide, please. And there is also a significant difference in the prescription of anticipatory medication based on people's ethnicity. In particular, if you are of Asian ethnicity, you were less likely to have anticipatory medication prescribed for common symptoms that are likely to occur in the last days of life. All of these areas, we would encourage you to have a look at your local populations and local practices. Next slide, please. And what we're going to do now is to try and have a look and try and help you work out where you can look to try and get a better understanding of the data. So though many of those things that we've just talked about are reported within the Nasal State of the Nations report itself, but there is also within this results and reporting section, there is also an annual data sheet, and there is a within that big table, there's an area that looks at equity, and you're able to look at the annual data sheet to see some of the other areas at which we have analysed the data for and where there are additional differences. So please do look at that area if you want to have a think about things in more detail. Next slide, please. We also know that for lots of different groups of people, an urgent certification and release is really of critical importance to their experience as somebody dies. And our data around this showed that there were about 2% of cases where there was an urgent release, but there were some additional cases where there was a request, but the staff were unable to complete that request. Next slide, please. So going on now to understanding your data in more detail, we're going to go through some of the areas on the data improvement tool. Next slide, please. So there are different views on the data and improvement tool, and we know that over recent months there had been some difficulties with it loading promptly. They seem to be resolved because of the hard work of the team to try and address the issues. So we hope that when you check to have a look at these things, you will be able to quickly appraise your local data. Next slide, please. So the dashboard view is a high-level view. There are across the top the different areas at which you can generate a dashboard for your local data. The important thing is there is now patient and carer tool dashboards, a key indicator summary dashboard, and then a dashboard for each of the individual primary drivers that we have, of which one of them, as we mentioned before, is around equitable care. It's important to remember that you still need to select your submission. It will default to an organisation in alphabetical order. So you need to check where it says example submission on this slide. You need to select your organisation there. And that will give you a high level view of where your results sit compared to the other people, for instance, in an acute hospital site, and your peer group, for instance, in the Midlands or in whichever locality you are in. Next slide, please. And then the overview section is the area where you can drill down and find a lot more detail about your data and understand things in much more detail. So this is where it's particularly useful if you're doing some quality improvement work relating to an area. And there is the option in this area to filter data, for instance, as we said before, by ethnicity or by spoken language, which may be particularly pertinent to what we're talking about today. Next slide, please. So that you select across the top the whether you're looking at the dashboard or the overview, and you can use the search function or the groupings to find out about your information in more detail. You need to check the year, so you can select whether you want 2025 data or 2026 data, as we've shown here. And you can have two tabs open on your same login if you want to look at those 2 years worth of data at the same time. Next slide, please. Just a reminder about checking that your submission is selected, that you can filter the data using the Filter Data tab, and that you can compare with a peer group, for instance, acute trusts or other trusts in your region. Next slide, please. And I find the easiest way to tap in what particular thing that I'm looking for rather than remembering where it fits. So if I'm wanting to, as for this presentation, think about some of the findings around ethnicity, then you can type that into the search function and it comes up with all of the different questions that are asked across the different nasal components that are relevant to that area. Next slide, please. And this is an example of if you do select to filter data, then these are the groups that come up at present. I would just say that you can filter by different markers, but it's important to be mindful that the more different filters that you select, the narrower your groups become, and therefore the smaller numbers are, which can make it more difficult to interpret. Next slide, please. So this gives an example of how you may look at your results and ascertain whether you have a similar profile of diversity within your population to the national picture, or whether things are different locally. Next slide. And we've touched on this one before, but these list options enable you to have a look at where your data sits and help you have a think about how well you record your information. Next slide, please. We're going to use now just a worked example based on an organisation's results and in an anonymised way to think of some of the aspects that may be relevant in patients of Asian ethnicity in this case. Next slide, please. When you're looking, as we said, at analysing any data locally, there is a challenge of finding out whether your numbers in your submission are sufficient in an area to be able to make widespread understanding of your local data. And so we do encourage you to, when you apply a filter, to think about the numbers within your submission. So in this worked example, the grouping in this organisation has submissions of around about 120, with somewhere between 21 and 30 people in their results being of Asian ethnicity, which I would consider to be a sufficient number to be making inferences about the care related to this finding. If your numbers are much smaller, you just need to be aware that the confidence of your findings may be subject to more individual variation. Next slide, please. So we see here that there are, in this organisation, that there is a slightly negative finding where less people have documentation of pain being reviewed. And this is worse across all ethnicities compared to the national population. Next slide. And here we talked earlier about anticipatory medication prescriptions. You will find we find in this group that there is a significant, well, what looks like a significantly different amount of people compared to the submission findings and the national findings who don't have anticipatory medications prescribed, and that is a much bigger proportion in people of Asian ethnicity. Next slide, please. And so I think as you're working through the information, you start to think about, well, what do we have data that might help us understand what's happening there? And if you then filter for whether somebody has a clearly recognized death or whether death is itself not unexpected, but the exact timing was not as clear, then we found in this organisation that the difference went away, or in fact that people in the Asian ethnicity group, so that all of the people who were recognised as dying did have anticipatory medication prescribed, which means that the decision making about anticipatory medicines and the difference may be around this point. And so on the next slide, it shows the data around recognition of dying. And so here you will see that in this group, there is a very significant difference in the way that the groups are in terms of recognition of dying. So it may be that this organisation would want to have a look at factors that are impacting on the way that dying is recognised and discussed with their Asian communities, and what learning is there to be from those populations to help us all make that experience of their care better, because we know from those findings earlier on that we showed that they are not reporting good experiences of care. So it's just to encourage you to look widely at data, that it can give you ideas about where you might want to focus some of your thoughts and questions. The solutions won't come from the data alone, but that can help you understand where it may be that some of your blockers and some of your differences lie. In order to be able to do this analysis work, though, you need to have recorded your ethnicity information. So that's why we have that focus on that as well, because these are all building blocks in the picture together. And I think if we move on to the next slide, we're going to start to hear from people who've then made a difference and gone away and tried to think about how to make changes to make this better. So our points from the nasal data to take away. Next slide. Do use the nasal audit, to drive improvements in the accuracy and the completion of demographic information, including ethnicity and spoken language. If those are completed accurately within your organisation, then you can use the nasal data to apply filters to help you understand the experiences of care locally to you for people in different groups there. Use your nasal data to deepen your understanding about what care looks like in your local hospital and what parts is care falling short. Can help identify areas that will require further improvement work, and we will continue to work nationally as well to be shining a light on that information. If you want to download of your information to be able to interrogate it in a different way, that is something that is also possible to request from the NACEL team. Next slide, please. So I'm now going to hand over to Emily Collis, who is a consultant in palliative medicine at UCLH, who is going to talk to us about their work improving care in this area. And then we will move on to hear from Sabrina.
Thank you. Hi. Yeah, so I'm delighted to join to talk in a really a broad brushstrokes way about the work we have done to try and provide more equitable care here at UCLH. Next slide, please. So we have 3 teams delivering broad palliative care at UCLH. It's a big tertiary or quaternary cancer and hematological centre, and we know from NACEL data that we have a more diverse population than is average in the UK, and also that we have a younger population because of the specialist care we provide. And we actually have 3 teams. So we have our specialist palliative care team, then we have an outpatient-based enhanced supportive care team, and then we have what was originally a quality improvement team, but now also does clinical work in the last days of life, which is our transforming end-of-life care team. So we came together, it was in 2 years ago now, so we're in the midpoint of our joint strategy from 2024 to 2028, and one of our key areas or key goals was to improve equitable care across the piece. And we knew from our NACEL data that there was room for improvement in terms of recording of both religion and ethnicity, and we really wanted to improve not just end-of-life care but also bereavement care across the patch. Next slide, please. So the first steps, we trained initially ourselves, so our specialist palliative care team and transforming end-of-life care team and cultural competence. There are 2 fantastic e-learning modules on e-learning for health, and so we got all of our team members to do that, and then we also did in our weekly education sessions 2 training sessions around cultural competence. We also taught people how to record ethnicity. It sounds silly, but we have an electronic patient record system. Our one is Epic, and not all staff were familiar or even aware that that was something that they could put in there, and so these basics are actually really important. We thought about our recording of spiritual assessment, and like many palliative and end-of-life care teams, I think we're probably pretty good at having these broad holistic conversations, and we're probably not very good at recording them or perhaps being entirely systematic about them. And so we investigated different models and chose the ELSA model of spiritual assessment to train staff in. And then I know at the moment with NACEL, we're thinking really focusing on ethnicity, but we were trying to start to think about equity in a more broader sense. So we did a workshop on LGBTQ+, workshops on deafness, and just trying to start to think more broadly about how we're going to address these things. We joined with our local community palliative care team to have a, if you like, palliative care specific EDI steering group, but then equally we joined in with the trust wide EDI group, which has helped us link in, for example, more from the HR perspective and the broader trust perspective, both around the recording and delivering of care. We've changed our practices, so thinking about putting a focus on discussing ethnicity and faith for every patient when they're discussed in our board rounds, ward rounds, and MDTs, and having chosen the ELSA template for spiritual needs assessment, how we incorporate that. So having a particular pro forma that's incorporated into our electronic patient review templates. Next slide, please. So we were already doing an annual audit of our decision making around TEP and DNA CPR because we know from the complaints and incidents that a lot of problems arise with communication, and we're wanting to look at the quality of that and starting to think about whether faith is incorporated, and from next year's audit it will be looking at whether there are differences by ethnicity in these conversations upstream of last days of life. And we've also been looking at, we have a large teenage and young adult cancer population, so also looking at that for these people. We've worked in a focused way with intensive care to support their training around cultural competence, and also with them have developed a multi-faith patient information booklet for staff that is in process, yet to be published. And then in terms of the care after death, we've launched a new bereavement policy, because what our concern was is that our bereavement support was ad hoc and based on strength of relationship, and that is very subject to bias. So we wanted to be more systematic. So we now complete a bereavement risk assessment or needs assessment template for all patients at risk of dying during the admission. We review at our weekly MDT, looking at the percentage of deaths with this template completed. Next slide, please. So what have we achieved so far? So thankfully, with a lot of hard work, our ethnicity recording has improved from 73% to 87%. Still work to do there. We have trained 100% of our staff in palliative care and end-of-life care, utilising the cultural competence training, and also we did longer in-depth face-to-face workshops for all ICU nursing staff. We have developed and launched a new sort of advanced communication skills course, but with a very much a faith-based and ethico-legal aspects, in collaboration with a Muslim scholar, Nalima. And actually it's the faith session of that which is one of the most highly evaluated in terms of thinking how we bring a holistic perspective to these discussions. So we've now actually run 12 of these courses. We've done one specific one which we tailored to the ICU setting for ICU consultants, and in a separate piece of work, colleagues and myself have launched a similar course for the TYA population, again with a different Muslim scholar, so Alima from Gosh, who has helped collaborate on incorporating the faith-based aspects on that one. And it's really interesting from the discussions to look at the parallels between faith and ethics and how that impacts upon our decision making. In terms of where we're at with the bereavement risk assessment, we have improved. I haven't got up-to-date data, but up until February, we've got about half of all patients improved from 11% in terms of ensuring we've done that bereavement risk assessment. Next slide, please. So what have we learned? I think in general, this joint strategy has effectively helped us drive and deliver a change in practice. I think when we have aligned our efforts with those of the broader trust, that has helped us achieve goals. The TEP Talks course is something we're really proud of. It's really highly evaluated. It's quite lean in terms of the staffing requirements, because rather than actual role plays, we have videotaped the role plays and just used two facilitators to help debrief attendees around that. And like I say, it's the faith-based and cultural considerations that seem to be one of the strongest learning points from that. And we're hoping to expand that to have a hematology focused variant of the course. Evidence does show us so far that our bereavement risk assessment tool has helped ensure that bereavement support is more equitable and more proportionate to need, but we're yet to see the evidence of that in our NACEL Carer survey. And the ELSA tool seems to be very effective in terms of helping us be more systematic and have more confidence in terms of documenting the broader perspectives, the faith-based and spiritual needs of our patients, again, we need to await the data to see where that has got us. So I think actually, from my perspective, happy to answer any questions. If you're put in the chat, then we can address those at the end. Many thanks.
Thank you so much, Emily. That was really great to hear what's going on at UCLH. And that case study is one of the 66 that has been selected to feature in the 2025 Good Practice Compendium, which you can log on to see on our website. And it has also been selected as one of 5 of those case studies to feature in our 2025 State of the Nations report, where you'll be able to read a fuller version of the case study. Emily and team are also award-winning for their work that they've done following the NACEL audit in influencing change that was recognised by HQIP's Clinical Audit Heroes last year. And again, you can read more about that. I can put the link in the chat. But that influencing change really comes across in the case study, Emily. That's something I'd really like to talk to you about at the end. So I'd now like to hand over to Dr. Sabrina Bajwa, who's going to wrap up for us and tell us what we can do next to continue improving equitable care. Thank you.
Thank you. And I'm delighted to follow Emily's fantastic presentation. So I'm here in my capacity as EDI lead for NACEL, but in addition, I'm a consultant working at King's College Hospital and Guy's in St Thomas's Hospital as well, and I'm a clinical academic at the Lee Saunders Institute with a specialist interest in equitable care at the end of life. And so I'm here today really to talk about the NACEL data and research evidence and how we can really apply that into practical action for services. Next slide, please. So I think really the fundamental message of my presentation is that equity is the focus of everything that we should be doing in terms of how we deliver care to these patients. If we treat everybody equally in terms of access, but we have inequitable services where we aren't considering individual people's needs, what happens and what has quite clearly been shown from our research is not only do we get unequal outcomes, but actually we can cause distress to these families and these patients, and that's something, you know, that none of us want to do. And really, it's a case of, as this cartoon shows, that one size really doesn't fit all. Next slide, please. So I think, first of all, I just wanted to talk about cultural competence versus cultural safety. So this is something that's coming out more and more in research, and within the policy research unit for palliative care, we've been looking at this quite closely and have looked at the barriers to patients accessing palliative care, and there is a large paper that's just about to come out about this, which I've referenced below. So the distinction between the two is crucial. So cultural competence assumes the problem is a knowledge gap in the clinician, and it can sometimes lead to tick box training. And so kind of here are what Pentecostal Christians believe about death. And, you know, I think that whilst that is really important to have a basic understanding of that, is that sometimes it can lead to stereotyping and doesn't change the system within which care is being delivered. But cultural safety asks a different question. It asks, does that patient feel safe? Do they feel respected and valued, and is what they need being met without fear of judgment and poor care? And really importantly, cultural safety names racism and experiences of injustice as an important part to losing trust in healthcare. So many of these communities have had a lifetime of racial injustice through various points in their lives in terms of education, housing, contact with the police. And actually, when you then come into the hospital setting and you're dying, you're at an extremely vulnerable part of your life. And how do we then expect these patients and families to then trust us and have that relationship when they've been ill-served throughout their lives and experienced that injustice? So cultural safety recognises that, and cultural safety training enables health professionals to think about that in every aspect of their contact with the patient and family. And really importantly, cultural safety is defined by the patient, and for them to say when they feel culturally safe, rather than saying that we as clinicians have done our cultural competence training and now everything's okay. Actually, what we need to consider is how the patient feels. That is the true important outcome that we need to measure. And the quote at the bottom is actually from the paper that we're going to publish with the Policy Research Unit about cultural safety. A really important part of cultural safety is having an open mind to learning and being genuinely curious. People will openly welcome you with open arms if you ask about them and are genuinely curious, but also recognising the lifetime of injustice that they might have experienced is so incredibly important. Next slide, please. So just to talk, first of all, about creating culturally safe environments. So the nasal data, as Rosie eloquently described, showed that bereaved respondents were less likely to report that staff behaved with compassion and care where the patient was from an ethnically diverse group. So part of this is because of the environments and systems that people work with haven't been designed for these groups. Palliative care has fundamentally been built on a white British model, and actually we need to think about how we shift from the development of a model of care to really think about those people who are on the margins. So within some research that we did during COVID, when we looked at the response of palliative care services to the COVID pandemic, COVPAL, it showed that the visiting restrictions had a disproportionate adverse impact on communities where there was a large family presence. And those are overwhelmingly those people from ethnically diverse groups. And there's often a cultural and religious obligation to visit at the end of life, and actually looking at policies to ensure that those are accommodated are incredibly important in delivering equitable care. So another thing that came out of our policy research unit work was some really positive aspects of delivering equitable care, which included having faith resources available within services, things like prayer boxes, and having or Quran cubes for the Muslim patients, but also having multi-faith spaces. And I think one of the things that has come out is really around names and how things are named, that having chaplaincy services is seen as negative and alienating other communities, and actually calling things multi-faith services is a lot more acceptable. So it's really important to think about language that we're using within our services. And also think about what you call yourself. And one of the things that has come out in research that has been done, that actually the name palliative care alienates some communities, and actually there are negative connotations to that name, which could lead to a barrier of people wanting to even access services. So I think there is more and more shift towards using symptom control and palliative care services as well. In terms of fast track processes, incredibly important for those who from the Muslim groups and Jewish groups as well, and really importantly, care of the body. And so these shouldn't be seen as specialist requests, and they're an essential part of care and should be made available. So it's really important. And one of the things that you can do is a cultural safety audit of your service, looking at things like your visiting policy and your faith resources. Next slide, please. So in terms of getting communication right, the nasal data reported that hospital staff were least likely to communicate sensitively with those important to the dying person when the person was from an ethnically diverse group. So communication barriers is one of the most consistently reported in equity. So palliative care, or the research shows us that palliative care services aren't reaching the Asian and Black group across the Caribbean and African communities equitably at all. You know, there was a large YouGov survey, which I've put on the right of this slide, which shows that in terms of awareness rate, there's a large discrepancy compared to white British population. And actually the deficit for that lies with the services. So if we haven't managed to reach those patients, or they don't understand what care we deliver, we need to think about how we are communicating that and how we are doing that within the hospitals in terms of the information leaflets that we have. Are they available in different languages, and have they been developed with communities as well? So on the left, I've put some as services that you could think about this. And really, one of the first most important things is assessing language needs at the point of referral, and making sure that we're using professional interpreters rather than family members. And at King's we have a video translating services on iPads as well. So as well as information leaflets about the service, you can have multilingual materials about every aspect of the care, including the dying process. And translation isn't enough, and actually they need to be co-produced by people from communities. And we've just recently done some work at King's where we've done that for breathlessness resources across 13 different languages with different communities as well. And really importantly, curiosity at every aspect and inquiry at every aspect is really important. And so the most important thing I think you can do as a clinician is ask a person what matters to them about their ethnicity, what matters to them about their religion. So tell me about your religion and what you would like us to consider when delivering your care, not make assumptions that because they're Pentecostal Christian, for example, that what they might want at the end of life, because that, I think that leads to conflict. Next slide, please. And so in terms of trust, I think trust is such a fundamental part of delivering equitable care. And I think, you know, as I touched on before, that lifetime of experience, I think, brings many of our patients to our hospital, certainly already feeling like they don't trust us. And to be honest, I can completely understand that. And it's our job as health professionals to win these people's trust. And I think that the nasal data showing that some of these patients are less likely to be recognised as dying. And part of that, I think, might be the fact that there has been that loss of trust, and then people aren't letting palliative care services in, and I think that needs to be developed. And I think a really important part of that for me is having an asset-based approach about these communities. So not, and I know it's hard considering that sometimes you see this data, but really not thinking what is wrong with these communities or seeing these communities as a problem that needs to be fixed. I think actually it's really about celebrating these communities, thinking about what do these communities already have in terms of assets. So these communities have existing networks, trusted voices. They've got amazing cultural knowledge, religious leaders, and built-in support structures. So actually, what we should be doing as palliative care services is absolutely acknowledging that and saying that we want to come in and help in any way in addition, but not to replace those really close-knit communities. And I think the most important message is that please don't superimpose a white British model of palliative care. So different communities have different relationships with death, dying, prognosis, family decision making in terms of autonomy, and actually it alienates families if we take the white British model and try in a very paternalistic way to say this is the right way to die. So neither model is more or less valid. So our job, I think, in delivering equitable care is to understand and respond to what the individual and families need. And it was really interesting, actually, in the COVPAL study that we did, where we had over 200 services that said that they treated everybody equally, that they gave the same version of their palliative care to all of the families. And actually, I think that is part of the problem. And really importantly, when you design your services and you change things in your services, that it's really important to get co-design. And I think sometimes we can have co-design which is led by people who are quite specialised in patient and public involvement. But actually what we need to do is go to the grassroots of those communities. So it's those people with the health literacy challenges, those people whose first language isn't English and need help from interpreters. Perhaps those are the people who we should actually be having co-design our services. Next slide, please. So the nasal data shows that those inequities across the outcome measures. So whilst there are things that we can do as individuals, workforce composition is a structural issue. So representation at all levels, including leadership, needs to happen. I think you end up with a very blinkered view of what services should look like otherwise. So seeing people in senior positions actually builds trust for patients and families and signals that the service is genuinely for them. And diverse volunteers, so pulling people from the communities to actually work within your palliative care services as volunteers is a brilliant bridge, and they can be cultural brokers. But I would like to say, as a caveat, so don't assume that, for example, as a staff member from a South Asian background, as I obviously am, that I would automatically understand the needs of every South Asian patient. And so we're not a homogenous group. So just be careful about the burden that you might place on those ethnically diverse staff. They very much need to be supported and celebrated in their role as well. Next slide, please. So I thought that I'd just list a few things that you could potentially do, and I think even if you were able to do a couple of these, that would be absolutely fantastic. So really importantly, as what Rosie touched on was around ethnicity recording rate. You cannot really truly understand inequity and the delivery of inequitable services and then track your improvement in any way unless you are accurately recording your ethnicity. So please do use the NACEL data and improvement tool and improve that figure for yourselves. Ask every patient their preferred language at referral, make it a standard field if it's not it already in your system, and utilise video language interpreters. Review your visiting policy to see if it accommodates larger or diverse families. Identify a trusted community voice to partner with, and thinking about those people who are the most vulnerable that you want to reach. It's always better to develop your service for those most on the margins, and then it's easier to adapt for everybody else. And actually think about not only cultural competency training, but think about that aspect of cultural safety training as well, in terms of thinking about the anti-racist approach and it being a building block to trust building as well. And really importantly, have outward facing targets. Use your NACEL data to set targets for yourself as a team and reporting to your board, and split all your outcomes by ethnicity. What gets measured can get changed, and if equity isn't on your governance agenda and looking at outcomes in that way, it won't change. And I think the final thing that I want to say is that sometimes it can seem really overwhelming, and that there's so much that needs to be changed that it can almost be a bit depressing. But what I want to really encourage you is that small changes matter. So that if you set yourself a target of doing one thing this cycle, this year, and then maybe another one next year, I think all of those small changes lead to a big change. So please do that. And my final slide is, next slide, please. My final slide is a resource that we developed after the COVPAL study. So, and I don't think the QR code has come up on the slide, but somebody's going to pop the link in the chat. But what this is a 26-minute film, which is based on the evidence from COVPAL. And it's a 26-minute film aimed at health professionals to teach you on the difference between equality and equity, which is done through a cartoon, but also to give you the tangible ways as an individual you can start delivering equitable care within your organisation. And also there are organisational changes that you can make as well. And as you will see from these pictures, that actually there is a diverse group which really talked to the way that we can deliver equitable care, and they were diverse health professionals that were working across the country, and it's actually really moving video. So please do watch if you're able to, and please do get everybody in your team to as well. So thank you.
Thank you so much, Sabrina. I watched the video when you sent it through at the beginning of the week, and it is really moving. I was captivated for the full 26 minutes, so I highly recommend it. Thank you both so much. I hope you all have questions. I certainly do. But before we move to open session and questions, I just want to finish with a few next steps. Next slide, please. And next slide again, please. Thank you. So this is the Good Practice Compendium. You can see Emily and team's case study on here, as well as 13 examples of equitable care. There are case studies from 2024 and 2025. So please do have a look. You can select your case studies by theme, for example, recognition or equitable care, or you can do a free search. So if there's something that's not in the theme that you are particularly interested in, there should be something in there that just gives you a little bit of insight as to what others are doing. Next slide, please. And this is our community of practice, which we are hard launching as of this week. So please do join. I think as of this morning, there were 32 members in the community. Let's aim to make it the biggest, loudest and most conversational community that's on the Q platform. We can pick up any conversations from today's webinar on that community of practice platform. I'm aware that many of you will probably need to head off from the session. Before you do, please do fill in our evaluation, which we're just going to pop in the chat for you in a minute. And I'm going to now ask for the recording to finish, please. And we're going to open to questions, comments and reflections.